Yeah, okay, fine. So just to start, you all know this anyway, but just talking about the genetics of sickle cell disease. So on the face of it, it's a very kind of simple genetic change resulting in the clinical manifestations that we see in sickle cell disease. So it's a single point mutation in the beta globin gene, which is located on chromosome 11, resulting in a single nucleotide substitution and a change of a single amino acid from glutamine to valine, which you can see here. And this is in contrast to some other genetic diseases like hemophilia A and B, for instance, where the genetic mutation involves often large deletions in part of the factor 8 and factor 9 genes. So here we're just talking about a single point mutation and a amino acid substitution. So the question, I guess, arises that, you know, in terms of the genetic, sickle cell is obviously a very kind of simple model, but why is there such a broad spectrum in terms of the kind of the clinical phenotypes of the disease, and how do we explain all the pathophysiology? Can we explain it just by an abnormality in the red cells, which the genetics would suggest it's a point mutation in the beta hemoglobin gene? Well, as I hope we'll see in the next few slides, the situation is a lot more complex than just a disease involving the red blood cells. So some of the genetic modifiers in sickle cell disease, just to mention, so there are subpopulations of individuals, particularly in certain areas of the world. We sometimes referred to individuals having haplotypes of sickle cell disease, and these haplotypes originate from different parts of the world. There are several described haplotypes, and there are some which include a raised hemoglobin level, so an endogenously raised hemoglobin level, which can be protective. Co-inheritance of alpha thalassemia along with sickle cell disease can ameliorate the phenotype. So that's another thing that can modify the severity of the disease. Okay, and there are others, there are lots more, but these are just the two common ones that I'm mentioning. Again, this is all stuff that you know, but in terms of the laboratory diagnosis of sickle cell disease, you know how it's made, predominantly on the blood, the full blood count showing anemia, and the blood film showing the classic appearances of the sickle cells, the elongated sickle-shaped cells, or sometimes boat cells. And the diagnosis really is made on hemoglobin separation or hemoglobin electrophoresis, which can be either done by gel electrophoresis or by high-performance liquid chromatography, or HPLC. And we'll see a plot of that on the next slide. And then, although this is rarely needed to confirm the diagnosis, beta globin gene analysis will demonstrate the mutation that we've seen earlier. There is one other test that sometimes is helpful as well, is the sickle solubility test, which particularly can be helpful in patients with sickle cell trait, where there's not obvious morphological features on the blood film. So this is a picture of a blood film in a couple of patients with sickle cell disease. Obviously here you can see this beautiful example of the sickle cells and quite a lot of target cells and some polychromasia, which is to be expected in a condition which results in chronic and episodic hemolysis, but with preserved bone marrow function. And here on the right side, another slide again showing these beautiful sickle cell shapes. Here is a boat-shaped cell and a nucleated red cell, again indicating increased erythropoietic turnover. And here is the HPLC plot in a patient with sickle cell trait. So here we can see the peak corresponding to hemoglobin A, and this is a peak corresponding to hemoglobin S. Obviously, in a patient with sickle cell disease, homozygous sickle cell disease, there would be no hemoglobin A. We would only see the large hemoglobin S peak, along with the minor hemoglobin fractions, hemoglobin A2, and fetal hemoglobin, which can sometimes be, as we already mentioned, elevated in patients with sickle cell disease. Okay, so moving on to the pathophysiology. So this is just a kind of a clinical overview of the events which leads to the clinical manifestations in sickle cell disease. So we all know that the main feature leading to the clinical manifestations is that due to polymerization of hemoglobin S, the red cells get distorted. The red cells get stretched by the long chains of polymerized hemoglobin S and distorted into these sickle cell shapes. And these tend to be rigid and dehydrated cells, which are not easily deformable like the normal red cells, and they tend to get occluded when they pass through the microvascular circulation. Okay, and predominantly microvascular circulation, including the cerebral circulation, pulmonary circulation, and other microvascular blood vessels. And this leads to the manifestation of vascular occlusion and the clinical crises that we see. So this really is talking about the vascular occlusion, the vasoocclusion side of the pathophysiology. But as we'll see, there is another side of the pathophysiology relating to the chronic hemolysis side of the disease. Okay, we won't dwell too much on this, but just to mention that the extent of polymerization, and I think the key thing on this slide to note is that hemoglobin S polymerization is really the key event which leads to all the downstream pathophysiological manifestations and events which occur. So this is really the trigger for everything, and everything will come back eventually to hemoglobin S polymerization. So this is really the kind of if we can target this polymerization and prevent that happening, then this should be the aim really of therapies to prevent the initiating step in all the downstream pathophysiological processes. And yeah, the other important thing to mention is that polymerization of hemoglobin S occurs under deoxygenated conditions. Okay, things that modify the extent of polymerization include the extent and duration of the deoxygenation, the intracellular HbS concentration, and the presence of fetal hemoglobin. So hemoglobin F within the cells can inhibit polymerization effectively. Okay, another part of the pathophysiology is that the red cells become dehydrated, and this is again due to the polymerization of hemoglobin S, leading to damage to the red cell membrane and damage to some of the important membrane channels, the ion channels, particularly the calcium activated potassium channels, or called the Gardose channels. They get disrupted, and therefore leading to loss of potassium and water from the cells, resulting in these very dense hyperosmolar red blood cells. And the red blood cells, when they adhere to the vascular endothelium, or when they occlude the vasculature, I should say, they produce oxygen-free radicals, free radicals that lead to upregulation of transcription factor NF-kappa B, and that leads to upregulation of cell surface adhesion molecules on the endothelium and also on other cells like platelets. We can see these here, and these are the molecules that promote adhesion of the red cells, not only the red cells, but other cell types onto the vascular endothelium, as we'll see. So I won't go into this. Okay, so what I mentioned earlier is that there are two processes downstream from the polymerization of hemoglobin S, leading to the clinical effects of sickle cell disease. And we've talked about vasoocclusion. And it's not only the vasoocclusion, but importantly, it's the vasoocclusion causing ischemia, but it's the reperfusion as well. So when you get the vascular occlusion and then you get restoration of blood flow, or what we call reperfusion, that is often associated with a lot of damage and pathology as well. But it's a reperfusion step which causes production of a lot of these free radicals. And then the other step in the pathophysiology is the hemolysis, the hemolytic anemia. And the reason why hemolysis causes the problems is due to nitric oxide depletion, and we'll come to that. Okay. So I just wanted to kind of highlight the fact that the vaso-occlusion is due not only to sickle red cells, okay, but in the capillaries, that is the primary processes that you get. Actually, the occlusion is due to sickling and adhesion of red cells to the endothelium. But in the postcapillary venules, the process is slightly different, and there's a lot more contribution from other cell types, the white blood cells and the platelets, that form aggregates with the red cells adhering to the endothelium. And in fact, the way it happens is that the white cells first are recruited onto the endothelium via the cell surface adhesion molecules, and then subsequent to the adhesion of white cells, the red cells adhere to the endothelium and to the white cells. So you get a kind of heterogeneous aggregate of different cell types involved in the vaso-occlusion. So we talked about the ischemia reperfusion pathophysiology, and just to highlight again that the reperfusion stage leads to release of inflammatory cytokines, activation of vascular oxidases. Okay, I'm just going to skip over again some of these slides because I think there's a bit too much detail on them. So coming on now to the hemolysis. So whereas the vascular occlusion is associated with a lot of the kind of acute manifestations that we see, so the painful vaso-occlusive crises, the acute chest syndromes, these are primarily due to the vaso-occlusion or the vascular occlusion. The hemolysis is linked to a lot of the chronic complications. Of course, cholelithiasis as well due to chronic hemolysis, but the leg ulcers, priapism, pulmonary hypertension is due to hemolysis, and vascular pathology due to nitric oxide depletion. So sickle vasculopathy results in endothelial dysfunction and proliferative changes in the vessel walls. Okay, and as we already said, can be associated with systemic and pulmonary hypertension. So the main reason why hemolysis results in the vasculopathy is, as I said, due to the nitric oxide depletion. So whereas hemoglobin under normal circumstances is neatly packaged into red blood cells, when hemoglobin is released from red blood cells and is found freely in the plasma, it can be extremely toxic, as it's a potent nitric oxide scavenger. Yep. So free plasma hemoglobin depletes nitric oxide by direct scavenging, but it also generates other, even more potent reactive oxygen species which scavenge nitric oxide. Yep. So just a bit of background about nitric oxide, as I'm sure you all know, it's produced by the endothelium, and it is one of the key regulators of vasodilator tone. Okay, so disruption of the nitric oxide interferes with the state of vasodilation of the vasculature and causes changes in the intima and other layers of the vascular wall. Can I just ask people to mute their microphones because I'm just getting some feedback. Nitric oxide also inhibits activation of platelets and coagulation, and inhibits expression of the NF-kappa B pathway, which we mentioned is key in causing expression of cell surface molecules, causing adhesion of the cells to the vascular wall. So these are all important roles of nitric oxide, and it's easy to see how depletion of nitric oxide can therefore cause a lot of the problems that we're seeing. As well as actually scavenging nitric oxide and reducing nitric oxide levels, another way by which free plasma hemoglobin interferes with nitric oxide activity is by blocking the endothelial nitric oxide signaling. Yeah, so you not only get actual reduction in nitric oxide levels, but you also get nitric oxide resistance. So it's a kind of like a double hit. Yep. And here you can see yet another pathway by which hemolysis causes reduction in the bioavailability of nitric oxide. Yep. So normally arginine is required. Hemolysis causes release of this enzyme arginase 1, which converts arginine to ornithine. And normally arginine is one of the key steps in nitric oxide production. So when arginine is converted to ornithine and concentrations of arginine are reduced, then there's reduced nitric oxide production. Okay. Yeah, so I mean, I think we've highlighted a few of the kind of pathophysiological mechanisms, but there are many, many more, and it's important to say that many of them are not particularly fully understood, but it is a very complex kind of interaction of different cell types and adhesion molecules, as well as the nitric oxide depletion, causing a lot of the clinical manifestations of sickle cell disease. So in summary, just to talk about the pathophysiology, as I mentioned, it's a disease which has a very simple genetic basis. However, there's a very complex dynamic pathophysiology, as we've said, involving many different cell types and adhesion molecules. However, again, just to highlight that the pivotal initiating event is the polymerization of hemoglobin S, and this is really responsible for all the other downstream pathophysiology. And the clinical manifestations are due both to the repeated ischemia, reperfusion, and also hemolysis with their associated complications. Yeah, and we've mentioned the interaction of different cell types. And really what I'm going to now go on to talk about for the remainder of the talk is that how understanding of the pathophysiology enables us to identify targets for particular therapies, and just talk about some of the important therapies in the last few years which have emerged from clinical trials that may be coming into mainstream therapeutic use for us in clinical practice. Okay, so this is again just to summarize the pathophysiology we talked about. Again, I won't dwell too much on that. Okay, so yeah, so this is a bit out of place, but before we talk about the new therapies, again, just to put into context the scale of the problem in terms of both global and in the UK, how many patients we're talking about that have sickle cell disease. So here you can see that it's a very significant global problem with an estimated 275,000 newborns every year, of which the majority are in sub-Saharan Africa. Yeah, and because of obviously the demographics of sickle cell disease, the majority of newborns are born in countries which have poor healthcare systems and are not very well resourced, and the majority of patients with sickle cell disease do not survive beyond 5 years of age. Okay, but having said that, in countries which are better resourced, with early recognition and prompt starting simple treatments like antibiotics and folic acid, the median survival has improved dramatically over the last few years. And these are some studies from the US and the UK, which we'll see that has basically estimated the survival of patients with sickle cell disease. Here you can see a US study, the Sickle Cell Cooperative study, which was done quite a while ago now, which estimated a median survival of 42 to 48 years, and some other studies, these are both from the US, in patients with SS and SC disease, and a study from the UK, which showed median survival for patients with homozygous sickle cell disease and S beta 0 thal of 67 years, and that was a single center study. And here we can see that although there has been a considerable improvement in the outcome and life expectancy in patients with sickle cell disease over the last few decades, and we can see here important milestones which have kind of led to these improvements in outcome, like starting penicillin, preventative penicillin, the availability of hydroxycarbamide, and the kind of initiation of transfusion therapy for stroke prevention. Although we can see that there's been this considerable improvement, we can still see that when we look at the overall population, and this is obviously looking at the US, we can see that there's still a large difference between the general population and sickle cell patients in terms of their life expected life survival or life expectancy. Looking a bit more closer to home in the UK, there are about 15,000 patients with sickle cell disease living in the UK, and approximately 70% live in the southeast of the country, around the Greater London area. There are about 350 new births of babies born with sickle cell disease per annum. And in 2010, the National Hemoglobinopathy Registry was set up to record data, events, outcomes on patients with sickle cell disease, and to try and get some better epidemiological data, as well as data to guide clinical management. So most of the data that we have on sickle cell patients now comes from the NHR. And as you know, that in the UK, we do have good antenatal and newborn screening programs to detect patients with sickle cell disease. So again, that was just a background to kind of highlight the importance of the therapies and put things into context. So I said that we'll use the kind of pathophysiological basis of the disease to think about therapies and what targets of the disease the therapies could be directed towards. So hydroxycarbamide is a treatment we've now had for about 30 plus years in sickle cell disease. So we'll talk about hydroxycarbamide in a bit more detail. Hydroxycarbamide is a deoxyribonucleotidase inhibitor, and its effects in sickle cell disease mainly relate to increasing the hemoglobin F level within the red blood cells. But and as we've seen earlier, increasing the hemoglobin F inhibits polymerization of hemoglobin S. Okay, but there are other effects of hydroxycarbamide apart from inducing hemoglobin F. Yeah, this process will normally take about 6 to 12 weeks to start seeing any results. But we often see that when we start patients on hydroxycarbamide, the clinical benefit can occur much quicker than that, much earlier, and that's due to some of the other effects of hydroxycarbamide, and they include reducing the white blood cell count. So we see that as a baseline, many patients with sickle cell disease often have a high white cell count, and this is interesting because when we see patients present with sickle cell disease and we see that they've got a high white cell count, we normally assume that that's due to some infection, but actually it can be a baseline for many patients with sickle cell disease. And as we've seen, the white cells obviously play a big part in the vaso-occlusion process. So hydroxycarbamide can lower the white cells, and it can also improve and increase the red cell hydration. So these are effects that can manifest quite quickly, whereas the induction of hemoglobin F can take a lot longer. Okay, we've seen how the potassium channels can get disrupted in sickle cells. So another target of therapy has been looking at Gardus channel blockers to stop the potassium leaking out of the cells and to stop the cells getting dehydrated. We'll talk a little bit more about voxelotor, which is a treatment that is now FDA approved in the USA, but not currently approved by the regulators in the UK, but it has undergone phase 3 clinical trials and has shown very promising, and is probably going to be one of the first pharmacological agents to be approved. Antiplatelet agents, these are all things I'm just putting on this slide, kind of things that have been kind of postulated and have been looked at in clinical trials, but obviously not all of them have been shown to have benefit, and not all of them have been taken forward into kind of more into larger scale clinical trials. So antiplatelet agents and anticoagulants, although theoretically it would appear that they may have some benefit, in clinical trials that was not really shown to be the case. So these are not things that are used kind of in mainstream treatment of patients with sickle cell disease, unless there are kind of more specific indications. So anti-adhesion agents. So we talked about the cell surface adhesion molecules, which play a large part in the pathophysiology, and some of the targets for these have been the selectin molecules and drugs or monoclonal antibodies which block the selectins. And these were based on preclinical animal studies with monoclonal antibodies in mouse sickle cell models, which showed beneficial clinical effects by blocking these p-selectins. Again, this is something that I'm going to talk about in a bit more detail, because again, these are particularly the p-selectin inhibitors, again, have been approved in the United States, FDA approved, and are being used, starting to be used in the kind of mainstream management of patients. But again, here, unfortunately, NICE has just recently rejected the kind of approval for mainstream use of p-selectin inhibitor crizanlizumab in sickle cell disease. But we'll talk about this drug in a bit more detail. And again, theoretically, nitric oxide and drugs which increase nitric oxide should be of benefit. But again, clinical trials have not been very promising, actually, and it's probably because we've not kind of found the right kind of targets and using the kind of right drug, targeting the right part of the nitric oxide pathway. For instance, L-arginine, the amino acid which gets depleted, as we've seen on that slide, due to the inhibition of the enzyme RBC arginase, has not really shown kind of clinical that much promise in clinical trials. L-glutamine is another drug which is licensed in the United States and is being used for treatment of sickle cell disease, although it's unclear really exactly how it works. The kind of mechanism is not entirely clear. Anti-inflammatories such as steroids again have been looked at in clinical trials, but not shown to have significant benefit, and again are not part of the kind of mainstream management of patients with sickle cell disease. Okay, so just to talk about hydroxycarbamide first, because this obviously has been the kind of mainstay treatment that has been available for a number of decades now. It was initially developed as a treatment for GI malignancies, but has been used for more than 30 years in sickle cell disease. And we've talked about the mechanism of action. It does also, as a kind of an effect of hydroxycarbamide, is that it increases the mean cell volume, and this can be a useful way of monitoring the kind of compliance of hydroxycarbamide is by looking at the MCV, as well as looking at the hemoglobin F levels. Side effects, and these are the things which lead to patients declining hydroxycarbamide, are concerns about its effects on fertility. So studies have shown that in females there's no significant effect on fertility caused by hydroxycarbamide. In males the situation is a bit less clear, although it's not. It's kind of, the question is kind of a little bit open in terms of impaired fertility in males, whether it's due to hydroxycarbamide or whether it's due to sickle cell disease, because we know that sickle cell itself has an effect on male fertility and numbers and quality of sperm in men. So patients who've been on hydroxycarbamide and then stop and have never had their fertility assessed before, afterwards, if their fertility is assessed, it's sometimes assumed and put down to hydroxycarbamide, but that's difficult to prove, and it may be the underlying sickle cell disease. However, we do recommend that all patients, male patients starting hydroxycarbamide, should have sperm cryopreservation done before they start. And prior to conception, if either male or female patients on hydroxycarbamide, or indeed if their partners are on hydroxycarbamide, then if their planning for a family, then the advice is to stop hydroxycarbamide 3 months in advance of attempted conception. The theoretical risk of leukemia is another major concern for patients and another reason why many patients decline hydroxycarbamide. But clinical studies, including the cooperative study, which I referred to earlier in the US, have shown no evidence of an increased risk of leukemia above the general population in patients taking hydroxycarbamide in sickle cell disease. Okay. And patients on hydroxycarbamide obviously do require close follow-up and monitoring for evidence of bone marrow suppression. So the next 2 slides, I'm sorry that they're just a bit busy. They're just the recommendations taken from the BSH guidelines on hydroxycarbamide in sickle cell disease. And these really are quite interesting. These are a few years old now, but they do basically show the progressive thinking on hydroxycarbamide in that we should be offering it to really more and more patients with sickle cell disease. Children particularly, I think the recommendation is that pretty much all children should be offered hydroxycarbamide, all children with sickle cell disease. And in adults, we can see here, if we just go through some of these recommendations. So the benefits of hydroxycarbamide should be discussed with all parents of children, adolescents and adults with homozygous sickle or sickle beta thal. I'm not sure whether we're doing this as well as we should really, but you know, this is a recommendation to discuss it with actually pretty much all patients. And in infants up to about 4 years of age, offer hydroxycarbamide regardless of the clinical severity. Yep. So what the guidelines are saying is that all children below this age should be offered hydroxycarbamide regardless of the clinical manifestation and phenotype. And in children greater than 42 months and adults and adolescents and adults, offer treatment in hydroxycarbamide. Again, implying that, you know, we should really be offering it to pretty much everyone. And in adults with SS and S beta 0 thal, who've had 3 or more sickle cell associated moderate to severe pain crises in a 12-month period, treat with hydroxycarbamide. So this is pretty prescriptive, isn't it? We're saying that, you know, in this situation, we should be treating these patients with hydroxycarbamide. And in adults and children who've had sickle pain that interferes with daily activities and quality of life, treat, again, pretty prescriptive again. And in patients with a history of severe or recurrent acute chest syndrome, treat with hydroxycarbamide. Yeah. So these are, you know, they have been for some time now, the kind of indications that we would normally offer hydroxycarbamide for. But I think that these guidelines go a step further and, you know, say that we really should be pushing hydroxycarbamide more in these patients. Just regarding going back to children, so one of the main indications previously for transfusions over hydroxycarbamide has been neurological complications of sickle cell disease, stroke, or high transcranial Doppler measurements, which we know is associated with a high risk of stroke. But there have been some studies looking at switching patients who have been on hydroxycarbamide for patients who've been on transfusions for raised transcranial Doppler velocities for 1 year, and then switching them to hydroxycarbamide. So there was a randomized study of switching to hydroxycarbamide or continuing on transfusions, and actually in that situation there was no significant difference in the stroke events in patients who have switched to hydroxycarbamide. However, in patients who have for secondary prevention, so patients who've had ischemic strokes or infarcts, transfusion therapy is still the standard treatment. Yeah, and as the guidelines recommend, hydroxycarbamide should be recommended as a second-line therapy when transfusions are contraindicated or unavailable. So apart from secondary stroke prevention, for all other indications, really hydroxycarbamide should be strongly considered. Yep, and I won't go through all of these other recommendations in the guideline, but other clinical chronic disease manifestations, including priapism, nephropathy, may all benefit from hydroxycarbamide. The one area where there's less data on its benefit is in pulmonary hypertension. Okay, So we're just going to talk about some of the other therapies. So I mentioned that we talked about voxelotor, which is, it's a molecule which binds to the oxygenated state of hemoglobin S and stabilizes that configuration of the oxygenated state. So essentially stopping and blocking the polymerization of hemoglobin S. And it has now gone through a multi-center phase 3 double-blind randomized trial involving 274 patients who are randomized, a 3-way randomization between 2 doses of voxelotor and placebo. The primary endpoint was to see an increase in hemoglobin by 10 grams per deciliter, which is 10 grams per deciliter, which is 1 gram per liter by 24 weeks, and also an improvement in hemolysis markers. And actually the study did show significant number of patients did reach this clinical endpoint. We've been also involved in these studies with voxelotor at our centre, and we've seen a lot of patients, again, who've increased their hemoglobin level quite significantly, well above the 1 gram per litre endpoint in the study, and a fair proportion of the patients have had a good clinical benefit in conjunction with the increased hemoglobin level. So as I've mentioned, this has been approved in the US, FDA approved, and we're waiting for the regulators in the UK to undergo the approval before NICE will give an opinion on its use. But voxelotor is one of the most promising new drug treatments at the moment. The other one is crizanlizumab, which is a monoclonal antibody binding to P-selectin, blocking the interaction with P-selectin and its ligand. And again, this has undergone extensive studies, including a phase 2 randomized double-blind placebo-controlled studies in patients who some of them were on hydroxycarbamide as well. And this was looked at in 198 patients in this study with all clinical phenotypes of sickle cell disease. Yeah, and again, they looked at 2 doses versus placebo, and this was administered intravenously every 4 weeks approximately, so 14 doses received over 52 weeks. And it showed that there was a significant reduction in the number of crises in patients who were on crizanlizumab versus placebo, and a increased time to the first crisis in patients on crizanlizumab compared with patients on placebo. Here you can see some of the side effects which were seen in the trial. Further to this very promising outcome in this study, it should actually be noted as well that the other kind of parameters that they looked at in the study were hemolysis markers, and those hemolysis markers were not significantly changed in patients who are on crizanlizumab. So as expected, a drug which blocks the adhesion of cells to the vascular endothelium works mainly by blocking vascular occlusion, rather than impacting on the hemolysis of pathophysiology of the disease. And further to this kind of promising outcome, crizanlizumab is now being looked at in different settings, and there's a current trial, again, which we are part of in this hospital, looking at crizanlizumab in patients with sickle nephropathy. So we're now looking, we know from this trial that it has benefits in terms of impacting on the acute complications of sickle cell disease, but now looking at whether it will also reduce some of the chronic manifestations and complications. So nephropathy is obviously one of the chronic complications, and that trial is ongoing. It's just been started fairly recently. So again, another promising drug, and as I said, one which has again been FDA approved in the United States. But NICE currently in the UK have rejected it in terms of treatment for patients with sickle cell disease. So just in the last few minutes, I'm just going to talk about some of the curative treatments, again, extremely exciting. Hematopoietic stem cell transplantation and gene therapy. So until recently, the NHS funded hematopoietic stem cell transplants in patients with sickle cell disease up until the age of 19 years. And that's obviously on the basis that younger patients were less likely to have accrued chronic disease complications and were likely to have a better outcome in terms of the transplant and have a much lower transplant-related mortality than adult patients who had already accumulated kind of end organ damage related to their sickle cell disease, which is obviously makes sense. However, the cutoff of 19 was very kind of arbitrary, and it was very, very strict. So any patient who had passed beyond their 19th birthday then became ineligible for a NHS-funded transplant. And therefore, we often saw this kind of mad rush in patients who were transitioning to try and get them worked up and try and get a transplant organised before they turned 19. However, the good news is that now the NHS, following some pilot studies, has agreed to fund transplants in adult patients as well with sickle cell disease, initially patients who've got a sibling donor. And I think that there are plans to introduce it to haploidentical donors as well, but for the time being, patients with matched sibling donors. So now centres are going to start offering that to adult patients as well. Gene therapy is the other major development in the last few years. I'm just going to talk a little bit about gene therapy. So gene therapy is obviously a very is a great option for patients who do not have a matched sibling donor or a haploidentical donor for a transplant. Okay, and gene therapy in general can be done using two approaches. One is using a lentiviral vector to introduce the beta hemoglobin gene into the stem cells. So essentially the patient will have myeloablative conditioning, and then stem cells will be collected from the patient, following which they'll have a myeloablative conditioning regime, and the cells will be manipulated using this lentiviral vector to insert the hemoglobin, beta hemoglobin gene into the cells, and then these cells will be reinfused into the patient. So that's one approach which has been used for some time now and shown very promising results. And the other approach is the CRISPR techniques to knock down BCL11A, which again is a very exciting approach. So this is a report from the New England Journal of Medicine in 2017 of one of the first patients treated in one of the centres in France, in Paris, with the lentiviral approach of gene therapy. He was a 13-year-old male with HBSS, and he had a good indication to have a curative treatment with multiple or recurrent acute complications and hip AVN. And he had a trial of hydroxycarbamide previously and was on prophylactic red cell transfusions. Yep, and this is the kind of procedure which I've just already outlined in terms of stem cell collection, mobilization and collection, pre-infusion conditioning, which is myeloablative. Most trials have used busulfan as a conditioning agent. And then while that patient is being prepared to receive the cells are sent off to a laboratory where they are transfected with the lentiviral vector containing the beta hemoglobin gene, and then the cells are re-infused into the patient resulting in immune reconstitution. Some of the very kind of clever techniques that have been used in this is, rather than just using the standard beta hemoglobin gene, they have modified the genetically modified the beta hemoglobin gene to to produce a terminal, a different terminal codon that causes interruption of hemoglobin S polymerization. And also, because of this manipulation of the genetic code of the beta hemoglobin gene, it can also be detected by PCR. So when a patient has undergone the stem cell infusion, but obviously the patient during the procedure will have been transfused as well during the myeloablative procedure, then this will enable differentiation between hemoglobin A, which is from transfused cells, versus hemoglobin A from the transfected stem cells, which the patient has, which are part of the patient's kind of hematopoiesis following stem cell infusion. So this is a very neat technique. So not only does it stop hemoglobin S polymerization, but it also enables detection of the hemoglobin which the patient has now started, hemoglobin A, which the patient has now started to produce, in contrast to transfused hemoglobin A. Yeah, it actually enables quantification, sorry, by HPLC as well, because this hemoglobin A has a different peak on the HPLC, separates differently from standard hemoglobin A, so it can actually be detected on HPLC as well as by PCR. Yep, so these are the results in that particular patient that we mentioned, who one of the first to undergo this therapy. We can see that there was a steady increase in the hemoglobin A, which the patient himself was producing, the modified hemoglobin A, reaching these levels 5.5 grams per deciliter and 5.7 grams per deciliter at month 15. So 48% of his hemoglobin was the hemoglobin A from the transfected cells. His last transfusion was on day 88, post infusion of the stem cells, and his total hemoglobin levels were stable between 10.6 and 12 grams per deciliter after month 6. So shows good reconstitution of hematopoiesis. And there were no major adverse events. This is looking in this patient in particular, but also from other studies that have been done using the same vector. Patient was discharged at day 50, and 15 months post-therapy, he had no sickle cell disease-related complications or hospitalization. So you can see this has actually transformed his life and transformed him from someone having sickle cell disease to not having sickle cell disease. And we can see an improvement in his biochemical markers as well. The other technique I mentioned was a CRISPR technique. So this can be done in two ways. CRISPR techniques can either be employed to correct the mutation in the beta hemoglobin gene and essentially turn it into a normal functioning beta globin gene. However, this is not the technique that has been used. The technique which has been used in the clinical setting is CRISPR technique to knock down a gene called BCL11A. BCL11A is a gene which represses fetal hemoglobin. So when the switch occurs from fetal hemoglobin production to hemoglobin A production, or in the case of a patient with sickle cell disease, the switch from fetal hemoglobin to hemoglobin S production, BCL11A is the gene that is involved in that switch. So if we can repress the BCL11A gene, knock it down, then this can reintroduce the production of fetal hemoglobin, gamma globin chains and fetal hemoglobin. So it's a very neat technique of increasing the fetal hemoglobin levels significantly. And just a point of note, BCL11A is present not only in the red cells, but in other cell types as well. And knocking down the BCL11A can actually have deleterious effects in the white blood cells. It can be leukemogenic. So actually, the technique that's employed is not to knock down the BCL11A gene itself, but a promoter gene of the BCL11A, which is present only in the red blood cells. So therefore, it doesn't affect the BCL11A expression in other cell types, only in the red blood cells. So again, this is a technique which is undergoing clinical trials at the moment. And in fact, Imperial is one of the centers which is taking part in this research. One of the principal investigators of this study is Professor De La Fuente, who's a pediatric hematologist at St. Mary's, who is involved in the transplant program for patients with sickle cell disease. And we're quite keen to find patients to refer and to recruit into this study, because clearly I think the effects and the kind of future looks very promising if we're able to use this kind of approach, meaning that we don't have to rely on patients having a matched donor. So hopefully this will be another one of the approaches that can be taken forward in the years to come. Right, I'm going to stop there. I know it's a lot I've gone through, but maybe if there are any questions, we can take those for a couple of minutes if there are any questions.